Good morning, guys. How many of us? How many people do we have here? Let me see. 10. Where is everyone? We need to be very fast. Good morning. Good morning. Yeah, thank you so much. Okay. Good morning. Good morning. Welcome. Perfect. I think we are up to 20 now, so we can start. So, guys, I will. You see, that's why I want us to have a lot of these classes so that I'll be able to have some time to explain some concepts. Today we are discussing water and electrolytes. And as I told you initially, water make up, a very large amount of your body compartments. Very, very important that you know that. And for you to be functioning effectively, you need to be balanced. It's all about balance, all right? If there is something that is too much in your body or too little in your body, it leads towards lack of balance in terms of homeostasis, and that becomes a problem, becomes a pathology. Very, very important. And this balance is an interaction. You understand? Just like the how your school is being managed, everybody here, your different schools, there is interaction between the professors, the students, and the administrative staffs, even the janitors, right? Everything has to be an interaction for there to be an equilibrium, balance. And once it shifts from the normal balance, that's homeostasis, to an abnormal level, up or down, plus or minus, it becomes what? A problem. So the major things that controls those balance in the body is fluid, electrolytes, and acid base, which is why we are discussing them. So there are very few things I want to point your attention to, which is this particular area that talks about the fluid compartments of the body. All right. So there are 65% intracellular fluid, 35% extracellular fluid. Now, they usually ask you a whole lot of questions on that extracellular fluid. A whole lot of questions. You understand? Like, you need to know the subdivisions, like how many percentage is in the interstitium, how many percentage is plasma, and how many percent is transcellular. And you need to know the meaning of transcellular fluids. All right? Transcellular fluids, as I mentioned, it's more like catch-all, like miscellaneous. Do you understand? So you need to bear that in mind. Also, you need to know how water flows. Hold on. So how water moves, that's another thing you need to understand. How water moves. So usually water moves easily through membranes using what? Osmotic gradients, and it changes. You understand? It changes. So if you go to this particular slide, so this slide tells you something very important, because I'm going to give you a question on it right now. so that you guys tell me the answer. Osmosis from one fluid compartment to another is determined by relative concentration of what? Solutes. So solutes determines how fluid moves from one place to another. That's why we have intracellular fluid and we have what? Extracellular fluid. And I told you the major intracellular fluids, right? That's the potassium. Intracellular electrolytes, that's potassium, especially cation, right? And when you're talking about extracellular, you're talking about what? Sodium. So you need to know which one is inside and which one is outside. Very, very important. So I'm going to ask this question very fast and you guys will give me your answer. Look at this question. I'm not going to give you options. So everybody give me your answer very fast. Write the answer. And you know the rule. You must give me an answer. That's the rule. Hurry up. Everybody. Where is the greatest volume of water in the body found? Quickly, guys. Are we... Why are we slow this morning? I hope you're not on the bed. If you're on the bed, get up. If you're on the bed, get up. Quickly. Where do we find the greatest volume of water in the body? Is it the ER post service? Frankie, please, I don't want to laugh this morning. Okay, guys, you guys are very, very correct. Now, I want you to look at the slide also. I want you to see the water gain and water loss, all right? So fluid balance, you have to maintain gain and losses to be equal to 2,500 ml per day. Very, very important that you know this. And when you're talking about gains come from two sources. It can be metabolic, which is the one your body is producing, and it can be the one that is brought to your body. So those are the two major ways water enters your body. So you ask yourself, which one is more? So that one, water comes into your body. We call it what? Preformed water. Extremely important that you know that. The one that you put water in your body. Preformed water. All right? About 2,300 meals per day. So ingested food is about 700 and drinking is 1,600. Extremely important that you know this. And metabolic, it's just 200 per day. So you need to know this classification because they can ask you, where is it more or where is it less? I'm going to give you some questions, but I needed us to look at different areas before that. So for loss, we have sensible, which is the one you see, and insensible, the one you can't see. Extremely important that you know this. Sensible, the one you can see. Insensible, the one you cannot see. You don't notice it. You understand? It just happens. You don't notice it. In this sensible, urine, you see, urine is 1,500 mils per day. So what did it tell you? Urine you lose more fluid in a day through urine, and you gain more fluid in a day by drinking. So that makes sense. Then this is obligatory water loss. This is a diagram that you must always remember because they can give you this diagram in exam. Now, another thing you need to know is about osmoreceptors. What did I tell you about receptors? If, for example, now you want to enter my house, do you understand? And there is a code on the door. You type in that code. The code receives the numbers and opens the door. That machine on the door that you type it in, you punch it in, is not what we call receptor. It receives signal from you. If it recognizes that signal, then it will do exactly what you asked it to do. That's the meaning of receptor. All right. So when we are talking about osmo, fluid, receptor, oh, the receptors that accept what? Fluid or respond to fluid changes. It can be up, it can be down. And the major is found where in the hypothalamus. That's something you cannot forget. You understand? So it's generally governed more by the osmotic receptors in the hypothalamus. So they communicate with, a lot of the neurons in the hypothalamus, the cerebral cortex, and they alter the level of fluid in plus or minus. You understand? So extremely important that you know this. Let me see. Okay, and also we discussed about ADH, antidiuretic hormone, produced by the hypothalamus and stored in the posterior pituitary. You should always remember that, stored in the posterior pituitary. You need to know exactly what ADH does because they ask a lot of ADH questions. All right. Then you need to know what long-term inhibition of test is and short-term inhibition of tests. I think I explained this one time, and if you have a problem with it, you can all guys. If you have a question, you can always just put it in the chat. I will definitely discuss it. This is time for it. Do you understand? This is time for it. So we have long-term regulation and short-term regulation. All right. Long-term regulation, like for example, if I drink water now, that water touching my lips will tell me that okay, I should be satisfied. That is short-term regulation. All right. But that water went down to my stomach, then to my small intestine. It will take it about maybe 30 minutes to maybe 1 hour to absorb into my bloodstream for my bloodstream to recognize that okay, I've drank water, so the test should stop. So for the meantime, before it enters my bloodstream, what is telling me to stop drinking water is the short-term inhibition. That's when that water touches my lips. That's a short-term inhibition. If there is no short-term inhibition, if I drink that water and it has not entered the bloodstream, I'll keep feeling thirsty. And you see me drinking water for the next 1 hour before it enters my bloodstream. So the person will overdrink water. So to avoid that, that's why we have what? Short-term inhibition. All right. So short-term and long-term inhibition. Extremely important that you know this. If you look at this, it said cooling and moistening of the mouth quenches test. Distension of the stomach and small intestines also quenches test. 30 to 40 minutes satisfaction. So, but if you just put fluid in your mouth and it quenches your thirst and you don't drink water, in the next 30 to 40 minutes, your body will recognize that there's no water that was absorbed from the GI and you start being thirsty again. Extremely important that you understand these two concepts. All right. Okay, guys. I want to ask you a few questions, and you look at this. And I want to ask you a question on antidiuretic hormone. So let me finish the question. That's exactly what I'm posting. Look at this question. What's the function of antidiuretic hormone? What is the function of antidiuretic hormone, guys? Let me give you options. This is A. This is B. This is C. This is D. And this is E. Answer, guys. Quickly. Quickly. Okay, you guys are so correct. The answer is B. Now let me answer your question. Let me see who asked that question. Yes, the answer is B. You're correct. Professor, does ADH have different purpose or role in ICF and ECF? No. ADH does not really have a dual purpose that splits across ICF and ECF, honestly. So, ADF specifically focus on ECF, extracellular compartments. Do you understand? That's where it's actually focused on. So it can have effects on ICF indirectly. Do you understand? Because what ADF, antidiuretic hormone actually does is that it acts as a signaling molecule on the outside of the target cell. It signals. Do you understand? So it triggers something we call G protein cyclic AMP. You understand? Cascade that fuses with the aquaporin pump. Aquaporin channels are channels, on the medullary interstitium. How do I explain it? Yes, medullary interstitium. So what they usually do is that these channels, they allow water to what? Passively reabsorb from the tubular fluid back into that interstitium. You understand? Then from there, vasaracta. Then from there, the capillaries. Vasaracta of the capillaries. Do you understand? So this results in adding pure water into the ECF, thereby lowering the ECF osmolarity. So that's what it does. It majorly focuses on the ECF, not the ICF. It can have an indirect, action on the ICF, but its major focus is on the ECF. Does it make sense, guys? You can't see my screen? I don't understand. Can't you see my hand? Can you see my hand? I'm doing wiggle, wiggle, wiggle. Can you see my hand? Yes or no? Yes, okay. Then maybe it's from your end. All right. So, guys, what ADH does is usually the extracellular fluid compartment. All right. Very, very important. It forces water into water reabsorption. It forces water reabsorption directly into the plasma, straight into the plasma. Do you understand? So decreasing the osmolarity. So that's why when you are dehydrated, ADH comes into play. Do you understand? I really want you guys to always remember this. Very important. Okay, let me ask you another question. I'm not giving you option, no. So you see, look at this question. Most body water intake is from dash, whereas most body water loss is via dash. Answer, guys. The options? No, I'm not placing any options. Because I expect you guys to have read this thing very well. I can only give you options when necessary. Quickly, guys. Perfect. So most body water intake is from drinking, whereas the loss is from urination or urine. Very, very important that you know that. Now, I want you to see these two questions and compare them. What governs fluid? Fluid intake is governed mainly by hypothalamic neurons called what? And this water output is largely controlled by varying dash. Let's go, guys. Water fluid intake is governed mainly by hypothalamic neurons called dash. Water output is largely controlled by varying dash. Come on, everybody has to make attempt though. Everybody here. Everybody has to make attempt. Come on, guys. No option. No, today you are creating your own options today. Okay, guys, you guys are extremely correct. Do you understand? Fluid intake is governed mainly by hypothalamic neurons. Make sense? Hypothalamic what? Neurons. Called osmoreceptors. We already discussed it. That's what I discussed like 2 slides away. And also, the fluid output is usually by varying amount of what? Urine. Chicken. Simple. Like, simple. So that makes sense because urine is the major thing that in a major way you push out fluid. You understand? So when it varies, then it regulates your fluid output. It makes common sense. Look at this question. I just typed it right now in. When you are dehydrated, osmoreceptors cause secretion of what? When you are dehydrated, osmoreceptors cause the secretion of what? Quickly, guys. Osmoreceptors cause the secretion of what? Please, if there's anything that is confusing you in fluid and electrolytes, ask that question here. I have time to respond. Keep going, keep going. You guys are extremely correct. Antidiuretic hormone. You must go and study antidiuretic hormone. You must know antidiuretic hormone in your fingertips. Honestly, you must know where it's produced. You must know where it's stored. You must know what secretes it. You must know what causes it to be secreted. Do you understand? You must know its pathology because you will be asked. There is a question I'm looking for. There a certain question. When you do your smart book, you see a lot of those questions. There are a lot of questions on diabetic insipidus. You should also know this. Do you understand? That was why that question Walid asked. I used it to explain ADH properly so that you guys will understand it. All right. Okay. So if you look at the slide currently, you will see exactly that question we're discussing. You understand? Control mechanisms of water output. Changes in urine volume linked to adjustments in sodium reabsorption is what causes fluid output. Only way to control water output significantly is through variation in what? In urine volume. That's why you need to study, because your questions are there embedded in your study materials. You understand? So you don't have any reason. Any school, no matter your school, you don't have any reason. All right. So this is further regulation of fluid output, control mechanism of water output from the last one. You remember the last slide is talking about what? Urine and sodium. This one is talking about ADH. ADH secretion is triggered by hypothalamus osmoreceptors in response to what? Dehydration, which is what I just explained. All right. Then these are the aquaporin pumps, and this is negative feedback for ADH. You guys must know this because you will be asked a whole lot of questions on it. This is negative feedback, and if you don't understand it, please ask that question now. I'll take any question at all. All right. So this is negative feedback. You understand? Of when there is dehydration. When there is dehydration? If you look at the diagram properly, for people that don't understand it, when there is dehydration, it means that there's low water in your body, right? So that's why you see the water arrow drops. And when there is low water, what will happen to osmolarity? It will increase. That's higher solutes, like what? Sodium. That's why you see high sodium here. So these two things tells the blood, you understand, that osmolarity has been elevated. And immediately, what will it stimulate? The hypothalamic what? Osmoreceptor. You can never forget that osmoreceptors. Now, when hypothalamic osmoreceptors are stimulated, what does it do? It goes to the pituitary and tells the pituitary, hey, I gave you ADH, right? Oh yeah, secrete it immediately. That's what it does. I gave you ADH, secrete it immediately. That's the first thing it does. And the second thing it does is that it will increase what? Test. So this is test. Immediately it increases your test. What do? Naturally, you go and ingest water. And when you ingest water, water increases, thereby bringing this guy back to normal. This water volume back to normal. That's what we are just telling you. That's feedback. Also, the ADH can go and stimulate the distal convoluted tubule and the collecting ducts. That's another question they will ask you. Where does ADH, where those aquaporin pumps, where are they found? The aquaporin channels that are stimulated by antidiuretic hormone, where are they found? Usually at distal convoluted tubule and also the collecting ducts. You cannot forget. So when it goes to that place, what does it do? It tells it, oh, this guy is dehydrated. He needs water in the ECF. So what do? Bring that water back from that urinary tube, right? So it takes water back. So it stimulates what? Reabsorption. That reabsorption does what? Reduces urine. So they will ask you again, what is the effect of antidiuretic hormone on urine? What is the effect of antidiuretic hormone on the blood? So it increases blood volume. If it increases blood volume, it automatically increases blood what? Pressure. And in terms of urine, what does it do? It reduces urine volume. It increases osmolarity of the urine. You reduces osmolarity of the blood. You see how I'm trying to, that's how you must check this thing. What is its effect on the blood? What is its effect on the urine? Okay. So let's talk about two specific disorders, because I'm going to ask you a question on it right now. Two specific disorders. You get? So sometimes fluid deficiency can happen. It can be over a long time, and it can be short period, which can be corrected. All right. If it happens over a long time, it can lead to circulatory loss, which is very, very problematic, because circulatory loss can lead to, a lot of organs shutting down, like the kidney can shut down. You understand? It can shut down the brain. It can cause immediate fatality. Very, very important that we know how to correct it, and we first of all understand it. So there are two major deficiencies. We have volume depletion and we have what? Dehydration. What is the difference between dehydration and volume depletion? That's what you must know. So if you look at this slide, volume depletion is hypovolemia, occurs when proportionate amounts of water and sodium are lost. Proportionate amount of water and sodium are lost without replacement. So what it means is, how do I explain it? If there's a lot of water in this place, there is a lot of sodium, which makes it equal, right? Now, suddenly, I push out a lot of water without pushing out equal amount of solute. That's exactly what they're telling you. So a lot of water is what? Lost, but there is a lot of what? Solute. So what will happen is the solute concentration will what? Go up, leading to what? Increase what? Osmolarity. Very, very important that you know that. Now, if you look at dehydration is body eliminates significantly more water than sodium. More water than sodium. So here, proportionate amount of sodium and water is lost. Here, sodium is lost, but no water. Do you understand? Sodium is lost, but no water. So very, very, very important. So body eliminates significantly more water than sodium here in dehydration. I hope I'm not confusing you. In dehydration, more water than sodium. In hypovolemia, more sodium than water. So it's not proportionate for here, but the other place it is proportionate. I'll give you a question. Don't worry. I'll give you a question so that you understand what I'm saying. Look at this question. Look at this question, guys. And look at the option. This is A. This is B. This is C. I have to explain this thing properly so that you guys will get it, because there are more than 20 questions on it and I'm not going to bring them all out. No time. This is D. So I need you guys to attempt this question, then we continue. Quickly, guys. Quickly, guys. Quickly, guys. I need you to attempt it before I explain it again. I need to explain it again because I don't think I explained it clearly. Quickly, quickly, quickly. Quickly, 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 quickly. Let's go. Okay, guys. Okay, so pay attention. Let me give you a better explanation. Pay attention. So if you have your paper, you can actually write if you want to jot down, all right? The major difference is what is lost. Put that in your head. The major difference is what is lost. This question can come in different formats, which I'm going to show you now. The major difference is in what is lost. If you're talking about hypovolemia, you understand, hypovolume, loss of water and sodium together. Proportionate, equal, loss of water and sodium together from the extracellular space. Whatever has been explained before, keep it and just open your head now so that you can understand this concept now. Because your questions, even your NCLEX questions, are usually about rationales. Do you understand? Even in the clinic, wherever you guys are working, you are those giving fluids, and you need to be able to know which fluid you are giving and which fluid you are not giving. So the major difference is in what is lost. For hypovolemia, is the loss of what? Water and sodium together from where? The ECF, extracellular space. Loss of water and sodium together from where? The extracellular space. Why dehydration is the loss of pure solute free, loss of pure solute free water alone. That's what dehydration is. You are losing only water, no solutes. So because of that, electrolyte is what? High. Or solutes are high because you are losing only water. But in terms of hypovolemia, you are losing both of them. You understand? So hypovolemia is isotonic fluid deficit. You understand? Isotonic fluid deficit. When fluid and electrolytes, specifically sodium, are lost in equal proportions from the ECF compartment. Very, very important. Very, very, very important. All right? So if you have any question, you can also ask me. There are a whole lot of examples that causes hypovolemia. And there are a whole lot of examples that causes what? Dehydration. Now, for example, if maybe somebody has an acute hemorrhage, that's as we answered in this question, that is hypovolemia. You see? Acute hemorrhage, hypovolemia. Vomiting, hypovolemia. Severe diarrhea, hypovolemia. That's why if somebody is vomiting, you don't give the person just water. No, because the person is not having what? Dehydration. So when you are giving the person fluid, you are giving the person also electrolyte, because that person that is vomiting is losing both fluid and what? Electrolyte together. I need you guys to remember this thing. And I'm trying to explain it as much as possible so that you can come back to this video. You understand? And what hypovolemia leads to is usually what? Hypovolemic shock. That's what we call it. Primarily hypovolemic shock. That's the clinical threat. You understand? And it can the shock can be in different ways. It can be blood pressure reduction. You understand? Cardiac increase the cardiac output. You see the person breathing so much. Do you understand? Because of low fluid. The person is trying to push for more circulation. You understand? So, but what you need to know at this level is the common causes, which is hemorrhage, vomiting, diarrhea. Those are the major things. And when you're talking about hypovolemia, things that usually dehydration, things that usually causes it is insufficient water intake. Specifically, insufficient water intake, excessive sweating. Because in your exam, they will give you these two concepts: excessive sweating. You understand? Maybe somebody is having hyperventilation. When you are having hyperventilation, you are breathing out a lot of what? Water. That can also lead to dehydration. Very, very important. Or even some endocrine disorders. So let me ask you guys, what is one example of an endocrine disorder that can lead to what? Dehydration. Quickly. Quickly. Quickly, guys. Where is everybody? Quickly, guys. Do we have only 4 people here? Where is the 20 something people here? Come on, guys. Yes, diabetic what? Diabetes insipidus. Don't just say diabetes. When you say diabetes, you are talking about yes, hyperventilation can lead to it. Yeah, but I'm talking about an endocrine disorder, diabetes insipidus. All right, because that is a problem with ADH. Bear that in mind. All right. So what you need to do right now is to draw a table: hypovolemia, dehydration. Do you understand? Hypovolemia, dehydration. Beside it, you can write characteristics. All right. First of all, under the characteristics, you write what is lost. You want to know what is lost because this is your exam pointers. Any exam you are taking, you're not just your school exam. What is lost? Hypovolemia, water, and electrolytes. That's how you just write it proportionately. And the electrolytes just put brackets sodium because that's the most important thing. That's what they can ask you. You understand? And the fact that it is sodium tells you that it is in the ECF. Yes, diabetes insipidus. Now, if you go to the column of dehydration, what do you put there? You put what? Pure solute water only. Solute-free water only. So only water, no sodium. So if water is going out, only sodium is what? Getting larger. But the other place, if if water and sodium leaves the same thing, you understand? So everything remain unchanged. All right. And also they will ask you about the plasma osmolarity. So after that number one, which is what is lost, come under it and write in the characteristic, write plasma osmolarity. Now in plasma osmolarity, under hypovolemia, what do you write? You write unchanged. Why is it unchanged? This common sense. Why is it unchanged? Because it's an isotonic fluid. So equal amount of sodium and equal amount of what? Water is lost proportionately. So it's isotonic change, meaning that it becomes what? The plasma osmolarity is unchanged. It's still the same number. It's unchanged. Then under the hydration, what do you write? You write elevated. The osmolarity is what? The plasma osmolarity is what? Thank you, Afwa. Under the hydration, you said elevated. So hypertonic. Elevated. Why? Because there is more sodium. Because only water is lost. So it makes sodium become more. Because only water is lost. Common sense. Then after that, come to number three. Number three, you write what? Number three, you write sodium levels. That makes sense. Sodium levels. Sodium levels. Under hypovolemia, what do you write? You write normal sodium level. Of course, because it's proportionate. Then under dehydration, you write what? Hypernatremia. You remember the meaning of hypernatremia? High sodium, above 145. Now, under, then you come down again, then you write what? Compartment affected. Compartment affected, because this is a high-level question that they can ask you. Compartment affected under the characteristics. Then in that line, if you come to hypovolemia, what do you write? You write ECF volume shrinks because hypovolemia affects what? ECF. Remember, we said sodium and water is lost. Do you understand? Where do you see sodium? ECF. Common sense. So that's how I want you to think in the exam hall. So ECF volume what? Shrinks. ICF remains unchanged for hypovolemia. ECF volume decreases. ICF volume remains unchanged. Under dehydration, both ECF and ICF volume does what? Shrinks. Because water is lost in the two compartments. So the two compartments are affected under dehydration. Then down you write cause. You can write cause in both of them. You guys know the cause already. I don't need to waste my time on it. Cause in hypovolemia, I can write dehydration, diarrhea, vomiting. In dehydration, you can write, lack of drinking water, hyperventilation, ADH problem, which is diabetes insipidus. All right. Now you also write on after the causes, down you still write clinical risk. Clinical risk. Hypovolemia, clinical risk, right? Cardiovascular collapse, hypovolemic shock. Under dehydration, what are you writing? You're writing neurological and coma. A neurological impairment and what? Coma. That's what dehydration can lead to. Make sense? Treatment. Hypovolemia. How do you treat hypovolemia? It makes common sense. You give an isotonic what? Fluid. What is an example of isotonic fluid? Normal saline, lactated ringers. Do you understand? I told you isotonic is anything 0.5% towards 0.9%. Normal saline is usually 0.9%. Once it's 1% and above, it becomes hypervolumic fluid or hypertonic fluid. Once it's less than 0.5, it becomes hypotonic fluid. And this person is losing water and salt. So give the person water and salt. So if somebody is having serious diarrhea and you are giving the person water, drink water, the person is not having dehydration. The person is having hypovolemia. You feel me? God. Then dehydration. What do you, if the person is dehydrated, what do you give to the person? Give the person hypotonic what? Fluid. Hypotonic fluid. Do you understand? All these 0.5% saline, or even 0.5 and down, 0.5% dextrose in water, or just give the person normal water for dehydration, and the person will slowly dehydrate. Any question, guys? Any question, guys? If you have a question, ask, or forever remain silent. Somebody's busy laughing. Yeah, this voice is saying it. So I've really described these things. I'm not happy with it myself that I described it properly. Okay. So yes, that hemorrhage answer is a decrease in water volume without significantly affecting osmolarity. Why? Because water and sodium is lost proportionately. So volume remains unchanged. You guys have to remember that too. Okay, let's see this question. Long-term inhibition of taste is mostly associated with which of the following? Yeah, these are the kind of questions I like to give options. This is 1. This is 2. A. This is B, rather. This is C. This is D. And this is E. Quickly, guys. Quickly, let's go. Long-term inhibition of taste is mostly associated with which of the following? This question. I didn't put, the option is not in the screen. The option is I put option in the chats. Yes. Screen is for my slide. Long-time inhibition of the, okay, I'll read it out. Long-time inhibition of taste is mostly associated with which of the following? A, cooling of the mouth. B, distension of the stomach by ingested water. C, a drop in blood osmolarity. D, a moistening of the mouth. And E, increased salivation. Yeah, it's in the chat. Let's fire up. Let's fire up, guys. If you have any concern, please just write 911 or emergency. Let's see how to treat it. Let's see how to treat your concern. Let's know the fluid to give your concern. Since we are discussing on fluid right now, so anybody that has a problem, it has to be fluid. Okay, guys, if you look at that question, it's a long-term inhibition. The fact that it tells you long-term, remove everything that is short-term in the question. Cooling of the mouth is it not short-term? Distension of the stomach is short-term. You see? Yeah, the cooling of the mouth and moistening of the mouth, what is the difference? You eliminate the two of them. So A and D eliminated. Distension of the stomach eliminated. The three of them are what? Short-term. Then the other one say increased salivation. You understand? It has nothing to do with long term. It just means that you are very well what? Hydrated. You understand? So that is also out. So what causes long-term inhibition is usually a drop in blood osmolarity. That's when your body knows that, oh, this person really needs what? Water. All right? Yeah, so the answer is C. Yes, correct. We call it intelligent elimination, yeah? You have to eliminate intelligently. Look at this question. Where are cells with aldosterone receptors found? There are two places. So you need to write the two places for me because I mentioned when we were talking about. When we were talking. Where are cells with aldosterone receptors found? No option. No, I don't know if you're waiting for option. You have to give me the two places quickly, guys. They asked for one, but no, I want to. Continue, guys. Where, quickly. Let's go, guys. Okay, you guys are very correct. It's found in the DCT and collecting ducts. You see? So, I really don't want you to, because they can give you something very similar. Like this question says, where are the cells with the aldosterone receptors found? You have adrenal cortex, adrenal medulla, posterior pituitary, proximal convolute tubu, distal convolute tubu. You know it's DCT. That question, they can give you exactly the same question, and the option will not be DCT. And you'll be looking for DCT. Hey, where is DCT? Where is DCT? There is no DCT. But there is what? Collecting duct. And you don't see it. So that's why I needed you guys to tell me the answer. And we discussed it, by the way. You understand? So DCT and collecting duct. All right. Okay. So this talking about fluid excess and fluid volume. It's just opposite of what we discussed initially. So you should look it up. So yeah, this is another thing I wanted to explain to you. Fluid sequestration. Now, before I explain to you, I want to ask you this question. Before I explain fluid sequestration properly. Wait. Hold on. Look at this question, guys. In which compartment would fluid accumulate in edema? Quickly, guys. In which compartment would fluid accumulate in edema? Are you waiting for option? I'm not giving you option. No. I'm not giving you option. Ah, 911. Okay, let's go. Let's keep it going. Let's keep it going, guys. Is it becoming tough? Okay, I'll need you to look at that slide. That's looking at you right now. The slide is looking at you right now. What is fluid sequestration? Fluid sequestration is what? When there's excess fluid in a particular place. So, guys, you see this my small room now. Let's assume that there is 100 liters of fluid supposedly in this place for this place to be equal. And in this my big wardrobe here, maybe there is supposed to be like 20 liters. In my toilet, there are supposed to be like maybe 10. Do you understand that kind of arrangement? That's called being proportional. What of a situation whereby suddenly in my toilet, instead of 10, there is what? There is 40. And the remaining 60 are here. Already, this system will become dehydrated, right? There will be low fluid in this system. You understand? There will be circulatory decline in this system. Why? Because the toilet decided to take more than it should not what? Take. That's what we call sequestration. So total body water may be normal. The entire water in this room may be normal. But circulating blood volume will drop. Why? Because one particular place decided to hold the other amount of water hostage. I don't know if you understand. So usually where this thing happens is we're in the interstitial spaces. So the answer is what? Tissue fluid or interstitial fluid. You cannot forget this. You need coffee? You don't need coffee. You need to go and make that concoction I always make when I come to school. All right. So most common form of sequestration is what? Edema. They will ask you in exam. What is most common form of what? Sequestration. And what is edema? Edema is abnormal accumulation of fluid, specifically or most usually in the interstitial spaces. Thank you. Not on, okay, yes, perfectly. On proportional water level. Perfect. In pockets, in specific place. Like, I don't know if I told you the story of a woman that came to the hospital. She was having placenta previa, and she was having intrauterine bleeding, right? There's bleeding inside, and that bleeding is, going to one particular place to stay without coming out. You are not seeing that bleeding physically, but it's just, accumulating in a particular place. If you check the total volume of water, of fluid in that woman's body, it's still equal, it's still normal. But the fluid available for circulation is declining because she's losing it to one particular space. Before you know it, that become what? Edematous abdomen. So even as she's pregnant, her abdomen will swell more and become stiff and hard. You understand? So that's just it. All right. So hemorrhage is another cause of fluid sequestration because blood pools in the tissue, and that blood that pools in the tissue is lost in circulation. All right. Pleural effusion is another one. The parietal pleura and the visceral pleura. In between them, there's a pleural cavity. That fluid in it, is what? Effusion. When there's accumulation in that particular place, it becomes what? Effusion, and it causes a lot of diseases like lung disease. So the answer to this question is what? Tissue fluid. All right. They can give you options like intracellular fluid, transcellular fluid, blood plasma, lymph. Please, the answer, if you just hear edema, go and pick tissue. Always. And I've explained how we came about to that conclusion. Hemorrhage. So, guys, I want you to tell me, what is the principal cation of ECF and ICF? No, I want you to, let's do it this way. What is the principal cation and principal anion of ECF? So I want to see how you write this thing now. You give me 4 answers. You write ECF, this and this. ICF, this and this. The first one should be cation. The second one should be anion. Cation, anion, cation, anion. Write it in one line and put it for me in the chat. Quickly, guys, to help me avoid a lot of questions. To which one? Which one are you asking? If you're asking the one I was talking about, in which compartment would fluid accumulate in edema, that's interstitial compartment, or tissue compartment. Interstitial fluid or tissue compartment, anyone? No, you need to write the 4 of them for me. ECF, cation, anion. ICF, cation, anion. Quickly, guys. ECF, potassium and chloride. ICF, sodium and let's go, guys. Let's go. Where is everybody? Oh, only one person made an attempt or two. I'm waiting for you guys. So. Okay, guys. So pay attention. All right. Let's understand this thing once and for all. For your exams, a lot of exams that you're gonna write. All right. So if you have a table, I want you guys to draw a table right now. You write fluid compartments, one line. Beside it, you write major cation. After that, you write major anion. So that you won't forget. Now, in the fluid compartment, you write extracellular fluid. That's outside, right? Major cation is sodium. Major anion is what? Chlorine. Under that major anion in ECF, you write secondary anion is bicarbonate. Because people, they make a lot of mistake in it. I've made a lot of mistake in it as well. You understand? Sometimes secondary anion in ECF bicarbonate. But chlorine is the major anion. They hardly ask you that one. What they usually focus on is sodium and chlorine. Remember that. Now come down, right? Intracellular fluid inside the cell. In major cation, in intracellular, major cation, potassium. Secondary under it, secondary cation, magnesium. But even if you know just potassium in it, we are good to go. In the anion parts, in ICF, major anion is phosphate. HPO4 2-, organic phosphate. Major anion in ICF. Then secondary anions are all these intracellular proteins. Know it and know peace. Chickener, that's the roadmap I'm going to give you. If you have any question, you can ask. That's the roadmap I'm going to give you. All right? Okay, hold on. That's my alarm. We started by 10. This is 11. Okay. Okay, I should go over it again. Okay. I need you to draw 3 tables. 3 columns. 1, 2, 3. In the first column, fluid compartment. Second column, major cation. Third column, major anion, rather. You get it to that point, therefore. Under the fluid compartment, right? First line, right? Extracellular fluid. ECF. That's outside the cell. Why I said outside the cell? Because they can give you a question that says, oh, what is the major cation outside the cell? You should know outside the cell is extracellular fluid. Yes, I'm taking it again. That's why I'm going over it again. So under extracellular fluid, go to the next beside it, under that major cation in extracellular fluid, write sodium. Then beside it, under the major anion in extracellular fluid, write what? Chloride. Then we ask you, what is the major? Yeah, I'm coming. What is the major cation for ECF? Sodium. What is the major anion? Chlorine. What other anion can we see inside the cell? Bicarbonate. So bicarbonate is a secondary anion, extracellular. Secondary anion, extracellular, bicarbonate, HCO3 minus. Intracellular. Down, if you go down, intracellular, let's go to intracellular, that's inside the cell. Under in intracellular, under what is it called? Under major cation, right? Potassium. That's the major intracellular cation, potassium. That's what takes care of your RMP, resting membrane potential. Potassium. Now, secondary cation, intracellular, is magnesium. It's not a major, but it's another. In case of you are writing an exam, they ask you where is magnesium found. Intracellular. Now, if you go to the anion part of the intracellular, the major anion is what? Phosphate, HPO42 minus, organic phosphate. And the secondary is, what did I say before? Intracellular proteins. Any question for me? Any question for me? This question, look at this question. It's a range question. What is the normal pH of the tissue fluid? It's a range question. From what to what? What's normal tissue fluid? Normal pH for tissue fluid, guys. Come on, guys. I was thinking this one would be very simple. Everybody will just be rushing the answer. Got it. Perfect. What is the pH for the normal tissue? Your normal tissue pH, what is it? Come on, let's go. Yes, you guys are extremely correct. It's 7.35 to 7.45. You can never forget that figure. Never. Eh? You dare not. So I want us to okay. Let me ask you this question: for an adult, what is the total body water, guys? For an average adult, what's the total body water for an average adult? Numbers question. What's the total body water of an average adult, guys? Hmm? Only 2 attempts. What is happening? Is he getting tough, guys? What is the total body water content of an average adult? Guys, why is this one very difficult? Why is it very difficult? Yes, the answer is what? 42 liters. All right. You can't forget that. It's actually an average anyway. Okay, guys, let's look at sodium. Quickly, guys. Quickly. Let's look at sodium because I need to ask you some questions on sodium. So functions of sodium. Sodium is one of the principal this thing we already know that. You know what it can do significantly. Then this is the sodium pump. Now, in terms of homeostasis, that's where I'm more interested. You understand? In terms of homeostasis, you as a normal adult needs 0.5 gram of sodium per day. Very, very important. Though American diet has 3 to 7 grams, but what you need is 0.5. So, guys, you need to mind the amount of sodium you take on a daily. You need to mind the amount of sodium you take on a daily. You need 0.5, and the average meal here is 3 to 7 grams. Okay. So the major concern is excretion of excess dietary sodium, right? Not even intake. Everybody takes sodium. You understand? And sodium concentration is coordinated by what? Aldosterone. Sodium concentration is coordinated by one, aldosterone. Aldosterone is salt retaining. You guys know about, remember the RAS system, right? Renin, angiotensin, aldosterone system, right? Very, very important that you remember that system. I discussed it in urinary. So if you can't remember it, please go to my urinary video and look it up again. You understand? So the primary role of aldosterone is what? To adjust sodium. That's the primary role. You understand? To adjust sodium excretion. So we have something we call hyponatremia and hyperkalemia. Hyponatremia, low sodium. Hyperkalemia, high sodium. Directly stimulates the adrenal. Hyperkalemia, high potassium rather, directly stimulates the adrenal cortex to secrete what? Aldosterone. So when there is low sodium, that's hyponatremia, You understand? It tells the body to secrete what? Aldosterone. Aldosterone increases the sodium back. When there's hyperkalemia, kalemia is high potassium. Potassium and sodium, they don't like each other. They just don't like each other. So when there is high sodium, there is low potassium. When there is low potassium, there is high sodium. They don't like staying in the same space. So because of that, when there is high potassium, it tells the body that, oh, sodium is low. Bam, aldosterone is secreted. And aldosterone comes, pushes out potassium, and increases sodium. Do you understand? Aldosterone is very partial. You understand? It's more interested in retaining what? Sodium. So hypotension stimulates its secretion also. So you see the things that stimulate secretion of sodium, you need to know. Secretion of aldosterone, rather, you need to know. Hyponatremia causes aldosterone to be secreted. Hyperkalemia causes aldosterone to be secreted. Hypotension causes aldosterone to be secreted. You need to write down these three things. They can ask you in any way. They can even tell you one of the following causes secretion of what? Aldosterone. You understand? They will tell you hyponatremia. You see? Hyperkalemia. You see? Hypotension. You keep wondering. Hyper. These people want to kill me. These people want to damage my head. It's not true. You need to understand it in Trateka, the way we are doing it right now. All right? This is a RAS system. You remember what the RAS system is about? RAS. Liver produces angiotensinogen, an inactive angiotensin. Kidney produces renin. This renin then breaks down, is the hormone that breaks down what? Angiotensinogen to what? Angiotensin 1, which is still inactive. And what happens? The lungs produce ACE. ACE will break down angiotensin 1 to angiotensin 2. This angiotensin 2 does three things. 1, vasoconstriction. 2, it causes you, it goes to your brain and makes you thirsty. And 3, it goes to the adrenals, the adrenal gland, especially in the first, in the cortex, the first region of the cortex, which is what? The glomerulosa, goes there and causes what? A mineralocorticoid to be produced. An example is what? Aldosterone. Extremely important that you can understand RAS system. I always explain it, so you can never forget. All right. So these are the ways it always does this. These are receptors, where receptors are found. This is the pumps. And this is action of what? Aldosterone. This is what aldosterone does. Very important. When aldosterone is produced, what does it do? Aldosterone is salt what? Retainer. What does aldosterone do? Extremely important. Look at it now. Aldosterone increases what? Potassium secretion. It pushes out potassium. 1. So if it pushes out potassium inside the urine, the urinary potassium will do what? Increase. Listen, guys, you have to be thinking, what is its effect in the urine and what is its effect in what? In the blood. Because one option can be telling you increase. You say, okay. No, you need to know increase where. So aldosterone increases urinary potassium because it pushes all the potassium into the urine, away from the blood. That's secretion. It promotes secretion of potassium. And what does it do to sodium? It brings sodium from the urine back into the blood. So let's refresh it. Aldosterone increases urinary potassium, decreases urinary sodium in the blood. It increases plasma sodium and decreases plasma potassium. This is how you write it. Because you need to know the effect in the urine and you need to know the effect in the blood. Let me ask you this question. Look at this question. Which of the following does not secrete aldosterone? Yes, secretion means pushing out from somewhere. If I want to secrete something now, for example, they say the antidiuretic hormone is produced in the hypothalamus, right? Secreted in the where? Or from the where? From the posterior pituitary. So hypothalamus will take posterior secrete. Oh yeah, secrete ADH. Secrete ADH. This person is dehydrated. ADH pushes it out. So secretion is pushing out. Reabsorption is taking back in. Does it make sense? So if you come to my house now, you get me angry, I secrete you out. And then you get out of my house. You understand? You're not paying my rent for me. Get out. You feel me? That's secretion. But if I like you very well, I say, come to my house. Come to my house. I'm reabsorbing you into my house. You feel me? Okay. So look at this question. Which of the following does not stimulate aldosterone secretion? Which one does not stimulate it? Which one does not stimulate it? This is A. This is B. This is C. This is D. This is E. Which of the following does not stimulate aldosterone secretion? We have hypotension, hyponatremia, hyperkalemia, high sodium concentration, and high blood potassium. Quickly. Quickly, guys. Which of the following does not, you see that word not changes the entire sentence. So you ask yourself, oh, but which one causes aldosterone secretion? Then you bring it all of them out. Quickly, guys, quickly, guys, quickly, guys, quickly, guys. Let's hit it. Let's hit it. Let's hit it. Yes, you guys are so correct. Think about it. Let's rule it out. When you have hypertension, of course, everybody knows hypertension means, like we want to increase. Hypertension is what stimulates the RAS system. Everybody knows that. It's as simple as that. That's what stimulates the RAS system. So automatically the fluid volume is low. So we want to bring in sodium so that water will follow sodium and it increases the fluid volume. So that makes sense. So hypertension causes aldosterone secretion, of course. Hyponatremia, low sodium, of course, we know that. Hyperkalemia, high potassium means no low sodium, the same thing. Look at the last option, high blood potassium concentration. What's the difference between high blood potassium concentration and hyperkalemia? You understand? So all these ones, they causes what? Aldosterone to be secreted. So high blood sodium concentration. If there's high blood sodium concentration, of course, water will follow it. So that person will be hypertensive, right? So automatically the person doesn't need aldosterone at that moment. So that's how you get your answer. Clean and clear. Look at this question. Following is not caused by hypernatremia. Which of the following is not caused by hypernatremia? We have water retention, we have edema, we have hypertension, we have interstitial fluid accumulation, we have a reduction in plasma volume. Which of the following is not caused by hypernatremia? Sorry, yes, hypernatremia, yeah. Which of the following is not caused by hypernatremia? First of all, what is hypernatremia? If you know what hypernatremia is, then you'll be able to know the cause. Quickly, guys. What is hypernatremia, guys? Yes, hypernatremia is too much sodium concentration in the plasma. That's hypernatremia, too much sodium concentration in the plasma. Thank you very much. So the answer to that question is a reduction in plasma volume doesn't cause hypernatremia. You understand? Now, I need you guys to look at the slide and look at more things about sodium, because sodium is the most significant. It's what causes the fluid movements. It's very, very significant. You understand? So elevated blood pressure inhibits what? Renin and angiotensin aldosterone mechanism. That makes sense. Do you understand? This is what ADH does here. You understand? High sodium concentration in the blood plasma stimulates the posterior lobe of the anterior pituitary to release what? ADH. So high sodium causes ADH what? Reduction. Release rather. Then the kidney, this ADH now makes the kidney to start absorbing water and slowly further increase in blood what? Sodium concentration. But if sodium levels drop, ADH release is what? Inhibited. So high sodium causes ADH release. Low sodium causes ADH not to be released. You need to understand that concept. Very, very important. All right. These are other things that could affect sodium, like nutritic peptides. They inhibit sodium what? Reabsorption. Nutritic peptides inhibit sodium what? Reabsorption. Do you understand? So this inhibition of sodium reabsorption inhibits water reabsorption. Sodium makes water come in. So nutritic peptide stops sodium reabsorption. Makes sense. Simple. That's why we can give it in hypertensive patients, because it's anything that will stop water from being increasing in the blood, anything that can stop blood volume from increasing, that means that thing inhibits sodium reabsorption. Simple, because sodium reabsorption increases blood volume. So it's a very straightforward thing. So it's the kidney eliminates sodium and water, lowering blood pressure. You understand? So nutritic peptide helps to lower blood pressure. It's a high blood pressure medication. Remember nutritic peptides. They may ask you in your exam. Other hormones like estrogen mimics aldosterone and retain water. Estrogen mimics aldosterone and retains water. Very important. Progesterone reduces sodium reabsorption. It has a diuretic effect. So it counters, progesterone counters estrogen. Very, very important. Progesterone counters what? Estrogen. Glucocorticoids promote sodium reabsorption. Yes, example of glucocorticoids, aldosterone. You understand? Remember that. All right. Okay. So this is hypernatremia, hyponatremia. We already discussed this. Hypernatremia, high concentration of sodium. What can lead to hypernatremia? There's another thing you need to know. IV saline from administration, water retention, hypertension, edema. You understand? Hyponatremia, a person loses a large volume of sweat or volume. You understand? Replacing it with drinking plain water can lead to what? Hyponatremia. Results in excess body water, quickly corrected by what? Excretion of excess water. So when you drink too much water, you urinate too much. Simple. That's just the language. These are the functions. This is for potassium. These are functions of potassium. You understand? Very, very important. This is the most abundant cation ICF. We've already discussed this, so I'm not going to talk about it. But another thing you need to remember, they can ask this in the question, is That is essential cofactor for protein synthesis and other metabolic processes. Very, very important. All right. And 90% of potassium in glomerular filtrate is reabsorbed by the PCT. This is a question. Can't find it, but I know it's there. So you mark it and remember it. 90% of potassium in glomerular filtrate is reabsorbed. Where? In the PCT. Remember that there are different arms. There is descending, there is ascending. You understand? Then there is PCT, there is DCT. There is collecting duct as well. So this one is majorly, potassium is majorly in the PCT. Though DCT and cortical portion of collecting ducts, can push out some potassium as well. You understand? But where it is majorly reabsorbed is what? In the PCT, 90% of the times. All right? And aldosterone really helps for this absorption. So this is hyperkalemia. What it does. This hypokalemia, what it does. Now, I need you guys to understand something. Hyperkalemia is when potassium is greater than 5.5, right? If concentration rises quickly, you understand? Maybe you have a crush injury. Guys, let's think about it. This is the ICF. Remember, there is a lot of what? ICF is the major intracellular cation. So if somebody has a crush injury, what do you think will happen to the person? A lot of cells will be busted open. If those cells are busted open, what do you think will happen to the potassium? Guys, somebody, crush injury. That's how I need you to understand this. This is this person. ICF is filled here. It will leak out. It will pour out. Not even leak. It will pour out. So a lot of potassium will move to the ECF. When it goes to the ECF, what does it do? That's the question that you ask yourself. So during crush injury, there is a high rise of potassium in the ECF. What does it do? Immediately, you understand? It makes nerve and muscles start acting abnormally. Nerve and muscles, they will start acting abnormally. Thank you. I know it pushes out from where to where? ICF to where? ECF. That is the problem with crush injury. It can lead to cardiac arrest. It will some of them will rush to the heart and start dragging the heart like this. Jiggy, 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 just like children playing. When you keep children in the house too much and you take them out like this, they play recklessly. They will go to the heart and be drawing the heart. Jiggy, jiggy, jiggy. The person will have what? Cardiac arrest. That's why when you are injecting somebody potassium chloride, you do it slowly over time. You don't just, if you want to kill somebody, potassium chloride, person dies. If you watch all these action movies, that's what they do. You understand? Because a lot of potassium will rush to the heart, squeeze the heart, compress it, excite it too much, and the heart will have what we call cardiac arrest. You understand? Cardiac arrest. And when you give it slowly, you understand? Slowly, slow onset, it inactivates voltage regulated sodium channels. Nerve and muscle cells can become less excitable. Like when you give it slowly, sodium makes excitability to happen, right? So when you give it slowly, some of them can go and affect the sodium. So sodium will no longer be able to enter the cell, thereby leading to low excitability. So it depends on, do I push it fast or do I push it too slow? Do you understand? Those things pushing it too slow can lead to low excitability because they can inactivate sodium. Pushing it too fast can kill the person, can cause cardiac arrest. Okay. This is hypokalemia. When there is potassium deficiency, you can lose potassium by sweating, chronic vomiting, diarrhea, excessive laxative, aldosterone secretion, or alkalosis. What does it lead to? Nerve and cell become less excitable, just like the other one I mentioned initially. It can lead to muscle weakness, loss of muscle tone, decreased reflexes, arrhythmia, and other activities. Very, very important that you know this, all right? This is hyperkalemia. This is hypokalemia, what it can lead to, all right? So this is chlorine. You should also know about chlorine. Read it up. Very, very important. Yeah. See this thing. This thing is also something that they usually ask. As sodium is retained, chloride ions passively follow. Chlorine is in love with sodium. It's in love with sodium. You can just not do without sodium. That's why even the one you cook with, we call it what? Sodium chloride. So anywhere sodium goes, chlorine passively follows like a sheep to be slaughtered. So you should remember that. All right. Okay. So I want to ask you this question. Yes, everybody. What is the most significant solute in determining the distribution of water among fluid compartments? In short, I want you to give me two answers at once. This is the second question. What is the most significant solute in determining the distribution of water among fluid compartments? Women have a tendency to retain water during part of the menstrual cycle because estrogen mimics the action of what? So I need you to write both the two questions side by side, the answers for the two questions. Quickly, guys. Quickly. Quickly, guys. Quickly, quickly, quickly. Quickly, quickly, quickly. Yes, you guys are so correct. For the first one, what is the most significant solute in determining the distribution of water among blood fluid compartment? We already discussed it. That's sodium. And women have the tendency, of course, we say aldosterone mimics what? The estrogen mimics what? Aldosterone. You understand? Why progesterone has an opposite effect, mind you. Your question can be progesterone. Your question can be aldosterone. No, aldosterone. Your question can be estrogen, and your question can be progesterone. Estrogen does exactly the same thing with aldosterone. Remember that. Progesterone is against them, so it does opposite. All right. Let's see. I discussed hyperkalemia. Let's see if you can remember what we said. Which of these conditions is not a result of hyperkalemia? Which one is not a result of hyperkalemia? Cells are more excitable. The resting MP, the RMP is more negative. The cells are partially depolarized. The cells are more sensitive to stimulation. There is less diffusion of potassium out of the cell. Quickly, guys. Remember, which of these is not a result of hyperkalemia? So what do you say? You ask yourself, what does hyperkalemia lead to? What is hyperkalemia? High potassium. Oh, what does high potassium lead to? Then you remove each of them. Anyone that's remaining should be the answer. Of course. Let's go, guys. Guys, let me see. D, this person say D, this person say B. Okay, guys, think about it. What did we discuss? Let me go back to this slide. Potassium. Maybe I left it. Let's look at hyperkalemia. What did I say about hyperkalemia? Hyperkalemia can be sharp rise or slow rise, right? Anyone that happens, potassium makes nerve muscles abnormally what? Excitable. So A is out. Yeah, of course. So A is what? Out. Cells are more excitable. Of course, that is hyperkalemia. And the question says, which of these is not a result of hyperkalemia? So A is out. Do you understand? Then look at E. There is less diffusion of potassium out of the cell. Less diffusion of potassium out of the cell. Which of these is not a result of hyperkalemia? Less diffusion of potassium out of the cell. Doesn't even make sense. Why? Because you have hyperkalemia, like there's high potassium in the extracellular fluid compartment already. So why are we talking about diffusion out of the cell? So E is out. Let's talk about D. The cells are more sensitive to stimulation. Of course, that's what the meaning of abnormally excitable. Eh? Uh-huh. If you are very excitable, you know what I mean now, excitability. That's abnormally excitable. So the truth of the matter is that that's D and A, the same thing. D and A, the same thing. Cells are more excitable. Cells are more sensitive to stimulation. The same thing. And it cannot be the answer. So that's the point. Sometimes when you don't understand the answer, but you understand the question, you can eliminate if you know what you are doing. That's why the school is hitting on concept. You don't need to cram questions. You need to understand the concept so that if they give you something similar, you'll be able to what? Understand it as time goes on. Be able to pick the right answer, even if you don't see exactly the same thing. So A is out, E is out, D is out. Then C says the cells are partially depolarized. Has nothing to do with this thing. You understand? Partially. It shouldn't even be partially depolarized. It's very, very, very well depolarized because of high excitability. So high depolarization. That's the meaning of excitability. So that one is out. Then this one says the resting membrane potential is more negative. It makes no sense. You understand? Potassium being in the extracellular fluid, you understand, does not make the resting membrane potential more negative. So the question is saying, which of these conditions is not a result of hyperkalemia? So hyperkalemia does not have anything to do with RMP being more negative. RMP is intracellular, not extracellular. And that is why it's the answer. The answer is B. When you're talking about hyperkalemia, you're talking about extracellular fluid. When you're talking about the resting membrane potential, you're talking about intracellular. Where is everybody? Are they going to church? Have we spent up to 2 hours? No, now we haven't spent up to 2 hours. I wanted us to spend only 2 hours. Okay, guys. Let me see if there's a similar question. Now look at hypokalemia. So hypokalemia is what causes that depolarization, that hyperpolarization. You understand? So guys, I need you to put it in your head. If you look at hypokalemia, it causes hyperpolarization. Hypokalemia. You understand? Hypokalemia. But when you talk about hyperkalemia, it doesn't cause hypopolarization. I'll look for a question for that anyway, so that you understand what I'm saying. This question is very straightforward. All of you know it. So let's see. Hypokalemia can result from all of the following, except we have chronic vomiting, we have diarrhea, we have heavy sweating, we have aldosterone hyposecretion, we have excessive use of laxative. Quickly, guys. The time is against us, so I need you to be faster. Hypokalemia can result from all of the following, except chronic vomiting, diarrhea, heavy sweating, aldosterone hyposecretion, excessive use of laxatives. What was the answer? What was the answer, guys? Chronic vomiting, diarrhea, heavy sweating, aldosterone hyposecretion, excessive use of laxatives. Hypokalemia can result I already posted it. Chronic vomiting, diarrhea, heavy sweating, aldosterone hyposecretion, excessive use of laxative. Which of them are not a cause of hypokalemia? It's telling you all of them are. Which one is not? You guys are so correct. The answer is D. Aldosterone hyposecretion. So the follow-up question is, aldosterone hyposecretion will lead to what? What is the pathology? Guys, anybody? Anybody? What is the pathology? Aldosterone deficiency. Nobody? Okay, guys. It's usually causes one pathology that we usually mention under aldosterone hyposecretion is Addison's disease. All right. Addison's disease is primary adrenal insufficiency. All right. It's most common clinical pathology. You must remember it's associated with aldosterone deficiency. You understand? It's actually an autoimmune condition where the autoantibodies, they selectively destroy all 3 layers of adrenal cortex. Imagine your adrenal cortex being destroyed. The 3 layers, the glomerulosa, the fasciculata, and the reticularis. You understand? That's exactly what happens in Addison's disease. So what is the after effect? The patient will now suffer from a total lack of what? Both mineralocorticoids, aldosterone, and even glucocorticoid, cortisol. So you see that patient not producing cortisol insufficiency, and also aldosterone insufficiency. Do you understand? And if aldosterone is insufficient, it leads to a whole lot of things. You understand? Hyponatremia. You know what hyponatremia can cause? You understand? Hypovolemia, hyperkalemia. Do you get? Even tubular acidosis, metabolic tubular acidosis. Yeah, so those are the things that it can lead to. Hypotension. Okay, that makes sense. All right. So, but I need you guys to remember that it has a lot of things. Now, clinically, it has a major effects clinically, like cardiovascular, biochemical, and even systemic. Do you understand? Like cardiovascular, it leads to orthostatic hypotension, dizziness, syncope, cardiac arrhythmia. A patient comes to the clinic and feeling this way. You want to check the patient's sodium and know what is happening. You understand? Maybe the sodium is low. Maybe the person has a aldosterone hyposecretion or Addison's. So it can have cardiovascular effects, can even lead to arrhythmia and kill the patient. It can have biochemical effect like hyponatremia, hyperkalemia, BUN will become elevated due to azotemia, metabolic acidosis. These are the things that, the biochemical implications of hyponatremia, of aldosterone hyposecretion. All right. In terms of systemic, we already discussed systemic, profound muscle weakness and fatigue. You understand? And you have this psychological yearning to eat salt, compensate for lack of salt. So, okay. I just decided to shed that light there. So this is chlorine. Oh, chlorine, and we know chlorine is the most abundant anion in the ECF. Remember that, most abundant in the ECF. So I've already given you the table initially. And let me ask this question. Let me see if you guys remember what I told you. Look at this question quickly. Oh, sorry. Look at this question. Chloride homeostasis is achieved mainly as a result of DASH. As a result of DASH homeostasis. Quickly. Quickly, my guys. Chloride homeostasis is achieved mainly as a result of dash homeostasis. Quickly, guys. This one is something that you guys can do like this now. Quickly. It's even on the slide, looking at it. So you see, if you study, you'll be able to know these things. You understand? There's nothing anybody can ask you that is outside what you are being taught. Why is everybody not responding? Do you need water? Do you guys need water? Today I'm not even drinking water. My cup. You need anointing. Okay, guys, look at the slide. I guess most of you didn't pay attention to this. Homeostasis, primary homeostasis that's achieved as an effect of sodium. You understand? We're talking about homeostasis of chloride. Strong attraction to sodium, potassium, calcium, which chloride passively follows. It follows all these three. Follows this man, followed this man, followed this man. So I don't know what that means for chloride. Follows this man. Any handsome man he sees, he follows. So as sodium is retained, chloride what? Ions passively follow. So, but it follows this guy. This is the main chick. All these ones are side hen. Okay. Then hyperchloremia, hypochloremia. All right. Look at calcium, guys. What does calcium do for you? Clotting factor in the blood, activates exocytosis of neurotransmitters and other cellular secretion. Of course, like if you check the muscular junction, when the action potential comes to that junction, that synaptic cleft, what does it do? Who can tell me what action potential does in the synaptic cleft when it comes down in the presynaptic cleft? What does that action potential do? Quickly. This is why I like in person more, because I would have just pointed to somebody now. Okay, I can actually call people here. Let me see. Yanelis, Afua, Rashina, Aizana, Frankie, Michael, quickly, guys. The question: when action in the presynaptic cleft, all right, of neuromuscular junction, when action potential comes to that cleft, what does it do? That's just what I want to know. What does it do, guys? What does it do? Somebody mentioned it. Let me see. Opens calcium channel. Of course, that's where I'm going to. No, it causes calcium. Let me tell you the sequence. It causes calcium channel to open. Calcium enters that presynaptic cleft. And what does calcium do? Calcium will burst the vesicles, which goes back to what we are discussing here. Look at it here. Let me shed it. Activates what? Exocytosis of neurotransmitters. It bursts those vesicles, and acetylcholine is pushed out from the vesicles into the synaptic space. Sorry, into the synaptic cleft. What I was talking about before was synaptic knob. This is synaptic cleft. Cleft is in between the two synapses. So action potential enters there. That action potential enters there with that acetylcholine that entered that cleft. We now go and match to postsynaptic acetylcholine receptors. That postsynaptic acetylcholine receptors, we now open the sodium channel. Sodium will now rush into the cell, causing depolarization. Potassium goes out, causing repolarization. Sodium goes in again, causing depolarization. Potassium goes out, causing repolarization. As they are going up and down, up and down, up and down, up and down, action potential will now be formed in the postsynaptic what? Cleft. You remember the sequence now? Then it will not enter through the T-tube. Action potential will enter through the T-tube. Push out the calcium in the sarcoplasmic reticulum, which goes and holds the doorknob. That's the troponin. You understand? The troponin will now open the door, tropomyosin. The tropomyosin will now open up, which is the door. We open up the active site of actin. Myosin will now come and lap on it, and they will cause contraction. So all these things starts from action potential in the presynaptic region. You understand? The nerve. Action potential came down, opens the channel for calcium. Calcium comes in and busts those vesicles. So that's one of the major functions of calcium. Activates exocytosis of neurotransmitters and other what? Secretions. So we are past 2 hours. Please, I want to use just 30 minutes of your time and I can leave you, all right? I know you want to go. Just 30 minutes. Serves as a second messenger for some hormones and neurotransmitters. Activates sliding filaments of mechanism of calcium. You see, calcium will also go and hold the troponin, open the tropomyosin, leading to what? Actin margin. So myosin margin on the active side of actin. That is what? Sliding mechanism of the muscle contraction, which leads to muscle contraction. So what it does is that it goes to the door handle and squeezes it. That's troponin. So you should remember this. You understand? Yes, calcium slow channels open. Yes. So you should understand it leads to strength in the strengthening the skeleton. All right. Then it maintains very low intracellular cells maintain very low intracellular calcium levels. Why? Because they want to prevent calcium from causing crystalline precipitation. All right. Very, very important. They pump out calcium. You understand? They keep intracellular concentration low. You understand? And instead of keeping it inside the cell, they will hide it in the what? In the sequester it in the smooth ER and release it when needed. That's what we call sequestration as well. All right. Then these are the things that regulates calcium. You need to know. Homeostasis is regulated by look at it, parathyroid hormone, calcitriol, which is vitamin D, and even calcitonin in children. What your duty is to go and know what is the relationship between parathyroid hormone and calcium. What is the relationship between calcitriol, which is the active form of calcium, vitamin D, and calcium? You need to know what imbalances it happens, like the imbalances, what it leads to, cardiac arrhythmia, weakness, and reduced excitability. Look at hypocalcemia. What leads to hypocalcemia? Look, vitamin D deficiency, diarrhea, pregnancy, acidosis, lactation, hypothyroidism, hyperthyroidism. So these things are things you need to know. I want to ask you some questions on calcium. Question number 1. This. Which of the following is not a role of calcium in the body? It's not. You see, That's why I said you must know each and every one of those roles we just discussed. All right? This is B. C. D. So which of the following is not a role of calcium in the body? It precipitates in muscle contraction. It is significant component of nucleic acids. They serve as second messengers. It activates exocytosis. It's important in blood clotting. Which of the following is not, guys, not. Come on, guys. Where is everybody? You guys are so correct. It's not a role of which of the following is not a role of calcium? It's precipitate muscle contraction. That's a role. They serve as second messenger. That's a role. It activates exocytosis. That's a role. It's important in clotting. That's its role. It's significant component of nucleic acid. No. I hope you've read genetics. I taught genetics, so if you don't know genetics very well, please go and watch the video so that you'll be able to understand a lot of things about what nucleic acid. All right. Remember the regulation. These are the regulations. Hormones affect bone deposition and resorption, intestinal absorption, and urinary excitation. So it's chiefly regulated by this and this. So let me ask you this question. No option. How is calcium concentration in the body regulated? Three major things regulate them. What are they? You need to type it for you to remember it. You need to type it for you to remember it, guys. Come on, guys. Come on, guys. Come on, guys. Quickly, quickly, quickly. Yes. So you guys are so correct. And all those things you mentioned are hormones, correct? So they are controlled by, regulated by hormones. So in case of they ask you hormones, which hormones? PTH, calcitriol. Calcitriol is active form of vitamin D, guys. All right. Normally it's cholecalciferol in the skin, then it goes to the liver and becomes calcidiol, then goes to the kidney and becomes calcitriol. Do you understand? They promote what? Calcium. Very, very important. Same thing in PTH, phosphate thrashing hormone. It pushes away phosphates to bring in calcium. So you need to understand it extremely. Okay, let's talk about phosphates quickly. Oh boy. Let's talk about phosphates quickly, all right? This is phosphates. Very, very important that you know functions of phosphates, where it's found. I've already discussed that. Inorganic phosphates of the body fluids are an equilibrium mixture of phosphates, this, monohydrogen, this is 4,3, this is 4,2, this is 4,1. Those are inorganic phosphates. So anytime you hear inorganic phosphates, those are what they are. And they are major components in nucleic acid. This is what they were talking about nucleic acid and not calcium. Major components in nucleic acids, phospholipids. You know what phospholipids is? You understand? If you look at the plasma membrane, you see the phospholipids, types of what? Lipids. The major type of lipid in the plasma membrane. There is part of ATP. This P is phosphate, P phosphate, CMP, P phosphate, creatinine, phosphate. Do you understand? So anything you see phosphate, that is phosphate. Phospholipid, phos. This first phos is what? Phosphate added with lipid. You see? This is nucleic acid. That makes sense. What do they really do? They activate many metabolic pathways. Many, many metabolic pathways. And they help to buffer the system. So they stabilize pH of the body fluid. So if you don't know about phosphate before, I need you to understand phosphate very, very, very well. You understand? How is phosphate regulated? They continually lost in the urine. If plasma concentration drops, the renal tubules absorbs phosphate. And what helps it very much? This parathyroid hormone. You see, I told you parathyroid, PTH, is phosphate thrashing hormone. It pushes away phosphate just because of what? It betrays phosphate just because of beautiful calcium. You see, wickedness. So parathyroid hormone increases the excretion of phosphates, which increases concentration of free calcium. Justice for calcium. It lowers ECF concentration of phosphates, minimizes the formation of what? Calcium phosphates, and helps support what? Plasma concentration of calcium concentration, right? Aha. Very, very important. Even if it's imbalanced, it can be tolerable by the body. So quickly, let me ask you 2 questions on phosphates, and I will leave phosphate. You have to be very fast because I don't have time. Please. This is option A. Please, as I'm posting it, you have to be looking at it acutely. Option B. Option C. Option D. Option E. Which of the following is a result of phosphate excretion from the body? Wow, nobody has responded. Pick A, B, C, D, E. Quickly, guys, quickly. Which of the following is a result of phosphate excretion from the body? Yes, the answer is B. An increase in free calcium in the ECF. You guys are wise. You guys are very, very, very wise. Okay, let's see this one also. Yes, the answer is B to that question. Which of the following accurately describes the inorganic phosphates in the body? Which one accurately describes the inorganic phosphates in the body? This is A. This is B. This is C. Oh, this is D. Which one? Which of the following accurately describes the inorganic phosphates of the body fluids? They are not a significant component of nucleic acids. They are not important for cell membrane structure. They are not necessary in the linking of endogenic with exogenic reaction. They form crystals with calcium in the presence of what? Calsequestrin. Okay. They participate in the activation of some enzymes. Quickly, guys. Oh boy. Quickly, guys. I have 5 minutes. Come on, guys. Are we tired? Don't worry. I just have 5 minutes so that you go and rest. I even think if you guys are free later today, we can actually have one more section later this evening, if you want. Discuss digestive instead of on Monday. Maybe you discuss it in your group, and if it works for you, tell me. Yes, the answer to that question is E, right? They participate in activation of some enzymes. Now, guys, I need you to also know some important information. pH of a solution is determined solely by hydrogen ions. You should know what an acid is and what a base is. Extremely important. All right. Now, buffers are extremely important because they help to mop up too much acid components and too much basic components, right? And you need to know that there are major buffer systems in the body. You understand? Very major buffer systems in the body. We have the bicarbonate, we have the phosphate, and we have the protein buffer. You cannot forget these things. So you understand? This is normal pH, 7.35 to 7.45. We already discussed it, right? There are things that can challenge the pH. It can be lactic acids from anaerobic respiration. It can be phosphoric acid from nucleic acid. It can be fatty acids and ketone from fat catabolism. It can be carbonic acid from carbon dioxide. They can ask you any of this. In short, there's a question about these 4 things. You should be asking yourself, oh, what can lead to too much acid in the body? That's what you ask yourself. But what can cause too much acid in the body? Say lactic, phosphoric, fatty, carbonic. You understand? Carbon dioxide, fat breakdown, acid. So you see, you are producing acid every minute. You are producing acid every minute. Same thing with this, every minute. Oh, sorry. I want to increase the lightening of my screen. So every minute, all right? So you need to, to remember this. Did I delete something? Oh, I was wondering where the thing is. So you need to remember this, all right? So the buffer system is any mechanism that resists change in the pH, all right? Converts acid or bases to weak ones. We have physiologic buffers. Remember how your body helps you to control output of acids, bases, or CO2. Yeah, urinary system buffers greatest quantity of acid. Respiratory system buffers within minutes. You need to know the difference between these two things. Extremely important. Then we have, okay, so here we have physiologic buffers. Here we have what? Chemical buffer. A substance that binds hydrogen and removes it from solution as its concentration begins to rise, or releases hydrogen into solution as its concentration falls. So it's all about bringing it back to normal. You understand? You must know this equation. This equation is extremely important. You see this equation? If I'm you, I'll go and write it in my book. All right. If I'm you, I'll go and write it in my book, because then we can ask you which of the following represents the complete chemical reaction for bicarbonate buffer system. You must know the equation. And how does this equation go? See, look at it. You see, this is CO and water. When they react together, what do they form? They form HCO3. This HCO3 splits and form this and this. You see? So if your system is in a basic form, it will favor forward reaction, because forward reaction produces what? Hydrogen. But if your system is in an acidic solution, it will favor what? Backward reaction, because backward reaction favors what? CO production, and you breathe out the CO2 production. Do you understand? So it depends on if you're acidic at the time, or you have alkalosis at the time. Your body moves in the two different directions. That's why this equation is called a redox reversible equation. All right, having an oxidation and a reduction reaction in one. You understand? So I have 1 minute. So remember the bicarbonate, phosphate, and protein buffer. And also, in terms of, hold on, let me see this. Okay, this is bicarbonate buffer. Remember, this is phosphate buffer. Now, this is protein buffer. I want to mention something about it. Very, very important. Protein have a very strong buffering activity. Very, very, very strong buffering activity. And the major protein, the most important buffer protein in the blood plasma is what? Albumin, because albumin makes up almost 90-something% of what protein in the blood, in the plasma. It's albumin. So automatically, if they're asking you about the major buffer system, you should be thinking of albumin. I don't know. I hope I'm making sense. You understand? And in electrolytes, let me see if I can see electrolytes. In electrolytes, they may ask you, okay, this is respiratory. In electrolytes, that's red blood cell. They may ask you what helps to buffer red blood cell. Guys, red blood cell, does it have albumin or fibrinogen? No. What it has is hemoglobin. So the most important protein that buffers erythrocyte is what? Hemoglobin. I'm telling you now, if you have paper and pen, you write that concept down. Do you understand? You need to know the major chemical buffers. Major chemical buffers. There is physiological buffers also. There are respiratory buffers. Major chemical buffers, bicarbonate, phosphate, protein. Major protein buffer in the plasma, you talk about albumin. Major protein buffer in erythrocytes, you talk about what? Hemoglobin. Okay. And you need to know what weak acid and strong acid is. I already discussed it. You understand? Weak base, strong base, weak acid, strong acid. All right? Very, very important. Very, very, very important. I'm almost done. 1 minute more. Let me see if there's something important here. Yeah, the kidney is also a very great buffer. All right? The kidney tubule secretes hydrogen. You understand? Kidney tubule secretes hydrogen into the tubular fluid. And when they secrete hydrogen, what are they bringing in? They're bringing in what? Sodium. You understand? So when they reabsorb sodium, they secrete hydrogen. Remember that. Wisdom. They secrete what? Sodium. They reabsorb, they secrete what? Hydrogen. They pour hydrogen into the urine and they reabsorb what? Sodium. Very important that you know that. I hope you guys remember these charts. I'm not going to discuss it, but remember the charts. Okay. So I think we did a justice to this. And also, protein buffer is the highest buffer. Protein buffer is the highest buffer. You say what? I should repeat chemical buffer? Like, are you talking about the examples? Bicarbonate, phosphate, and protein. Bicarbonate, phosphate, protein. Look at how you have to know this thing. Chemical buffer, bicarbonate, phosphate, and protein. You understand? They always ask it in every exams. You understand? Then in the plasma, what is the major protein? Albumin. So automatically, albumin is the major buffer protein. In the erythrocyte, that's red blood cell, what's the major protein? Hemoglobin. So automatically, hemoglobin wins it. Do you understand? So that's what I'm just trying to say. And you need to know the interaction between hydrogen and what? Sodium. Extremely important. And protein is the major buffer system. You know that. Everybody knows that. Protein is major buffer system. You understand? And how does respiratory work? I've already told you. Respiratory, you breathe out what? CO2. Removal of what? CO2. That's respiratory. Like when somebody has the acidosis, hyperventilation, the person is pouring out CO2. Why? Because if the person holds CO2, that CO2 will still react with water and form what? Acid, and which we don't want. So what it favors backward reaction. That's production of CO2, pushing it out by respiration. That is hyperventilation. Ventilation. That's why you see all these people that have diabetic ketoacidosis. That's how they breathe. All right? Very, very important that you know this. And if somebody is having alkalosis, what do? I'll just tie the person's face with clothes. And the person is breathing in the clothes and breathing out CO2 and reabsorbing CO2. You cover the person so that the person will be taking back that CO2 is producing. So that CO2 goes back into the system, reacts with water and form what? Acid. So the alkalosis will be reduced. Homeostasis will be formed. We are looking for balance. It's all about balance. All right? Yes. So remember that. I think that's what we have for today. Anybody has a question for me? You guys remember the interaction between potassium and sodium, correct? The active transport between potassium and sodium. You guys remember in this diagram, potassium and sodium? Look at the two of them. Yeah, look at it. Potassium and sodium. It's an antiport reaction. Potassium and sodium. Very, very important. Okay. So do anybody have a question for me? More question added to the ones I've already answered. Anybody? So remember this equation, extremely important. Let me see if there's something else I forgot to mention. Okay, yeah, this protein buffers, you guys should remember the buffering activity is because of the carboxyl side group, all right? Even an amino side group. So carboxyl side group and amino side group. COOH and what? NH2. You understand? So you need to know which one does it give to drop. When pH begins to rise, COOH side chain releases what? Hydrogen. When it begins to rise. You understand? So increase in pH activates COOH, but decrease in pH activates NH2. So when they're asking you that question, you should know which one are they asking. Is it COOH or is it what? NH2? COOH or NH2? COOH or NH2? You understand? Increasing, one is for increase, one is for what? Reduction. So decrease, so proteins can buffer a drop in pH with their amino group NH2 for drop in pH. And when there is increase in pH, they buffer it with what? COOH. They know that and know peace. Diagram? No, I don't have time for it now. I don't have time for it now. Okay, guys. So I think that will be it. I will encourage you go and read your slides as well. Watch the videos as many times as possible. Also, if I'm you, if I read a particular topic, maybe buffer system, I go to my AI and tell my AI to generate 20 questions for me on buffer system. Simple. And you attempt those questions. The truth of the matter is that it will generate you some of these questions. Same thing. You understand? Because AI go online and searches a whole lot of questions. So the more questions you answer by yourself, right, on a particular topic, the more you know that topic. But first of all, you need to read that topic and understand what? The concept. That's why the review does not substitute for your slides, does not substitute for the lectures or whatever. All right? And you don't need to cram the questions. You need to just understand it, know how we answered it. How do we arrive to these answers? Oh, look at the options. Oh, how are these options wrong? Because if it's wrong in this concept, it can be right in the other concept. So you need to remember this, all right? So guys, thank you very much. I have to stop now because we've spent 2 hours, 38 minutes. I wanted us to spend just 2 hours. You guys voluntarily agreed to give me extra 30 minutes, and I took 8 minutes by force. All right. So I will see you later. If you want us to have a session this evening, because I think I'll be free from 8. If you want us to have a session, 2-hour session as well, maybe we'll discuss digestive system like this. You discuss it in your group, create a pool, and make me know. All right? So thank you guys very much. Nice having you. If you have a question, you can always ask me in the next session. All right. So I'm going to go off in the next 30 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Okay, guys, thank you so much. I appreciate everything. So please go and read. You need to read these things as many times as possible, all right? If you still want us to discuss it privately, you can always tell me. I can set up a Zoom and we discuss more because I'll be discussing with some other people. Yeah, no, discuss that in your group and make me create a pool and know how many people are available and let me know, right? So talk to you later. I'm going to go off now. I'm going to off the stream. Sometimes I don't see the button to off end stream. Okay, I see it now.